Hello and welcome to the 11th lecture. We're going to talk all about neurology for the AANP and the ANCC exam. No delay, let's just get right into the content. All right, so let's start the discussion talking about tremors. It's important to be able to differentiate between a rest tremor and an action tremor. So a rest tremor occurs in a body part that's not being used or at rest. And then an action tremor, it's more common, and this occurs in a body part that is being currently used or in action. So essential tremor, this is the most common neurological cause for an action tremor, and the incidence of this increases with age, although it can affect younger patients, and up to 70% of them actually report having a family history of essential tremor. And so there's definitely a big familial component. So symptoms of essential tremor include bilateral tremor of the hands with action, and then the absence of those neurological symptoms or neurological deficits. They can experience the tremor in additional places like their head or their voice, but this is not typical. This is not as likely. Generally, the textbook essential tremor would be bilateral tremor of the hands. The patient can also realize that their symptoms improve when they have a little bit of alcohol. And so this shows you that they are able to suppress those symptoms with the use of that. So diagnosis of essential tremor, though, it's made clinically with patients that present with the following 4 characteristics. So 1, bilateral arm tremor. 2, with or without tremor in other locations, so that's not needed for diagnosis. 3, for a minimum of 3 years, and then 4, without neurological signs or symptoms. And those are the qualities that you look for when diagnosing a patient with essential tremor. Basic lab work should be done, of course, to rule out any electrolyte imbalances, so specifically hypocalcemia. We know that low calcium levels can cause muscle spasms, and we want to rule this out. Also, thyroid function. We also know that hyperthyroidism can cause a side effect of tremor, and so we want to make sure that that is not what's going on with the patient as well. For pharmacological treatment of the essential tremor, a couple of different medications that are used. Again, propranolol, that is used for mild or situational tremor. Remember, though, that is a beta blocker, and so we want to definitely be cautious with who we are prescribing that to. And then if the patient has more frequent and severe symptoms, the next option listed is an agent called primidone. This medication has a lot of negative side effects, and if you read the literature, it says that this medication, if they're using it, should be really managed by someone who's specializing in neurology. So in the circumstance that the propranolol is ineffective, these patients would be referred and managed by neurology. Parkinson's disease, this is the most common progressive neurodegenerative movement disorder. It rarely occurs in persons younger than 40 years of age, and it's the most common cause for a rest tremor. So the classic patient with Parkinson's disease presents with a rest tremor, also referred to as a pill rolling tremor, and this is because the patient can appear as though they are rolling a pill in their fingers. Also, bradykinesia, this is seen, and this is slow onset of movement. Also, rigidity, this typically begins unilaterally, and then as the disease progresses, that rigidity can spread. Other symptoms include shuffling gait, postural instability, cognitive dysfunction, and then mood disorders. The symptoms that occur with Parkinson's, they are due to the continued degeneration of dopamine-producing neurons. In addition to the motor symptoms, we can also see non-motor manifestations as well. So examples of non-motor symptoms would be cognitive dysfunction. This most commonly affects either decision-making or multitasking. We can also see psychosis, mood disorders, sleep disturbances. And so remember, this disease, this is a result from continued degeneration of the neurons that produce dopamine. And people often think of dopamine as like the happy chemical. And because it is, it's responsible for the feelings of pleasure and motivation. So it's clear why this would produce these non-motor symptoms as well. Treatment of mild Parkinson's consists of monoamine oxidase type B inhibitors and dopamine agonists. And examples of these agents that belong to these classes, they're listed here on the slide. So I'll see if I can say some of these drug names, but the MAO-B inhibitors, so examples include razagiline, safinamide, and selagaline. I always think it's really important to really look at these medications and just build familiarity with them so you're able to build a bigger picture when you're looking at your patient and their med list. So dopamine agonists, there's bromocriptine, pramipixole, oh no, ropinirole. These are very hard. So I'm going to suggest that for now on, just read them and I'll stop trying to say them out loud. However, once this disease begins to affect the patient's quality of life, carbidopa, levodopa, and we've all heard of this medication, and that's easier to say. That's actually more fun to say. But once their symptoms are really affecting their quality of life, carbidopa, levodopa is going to be indicated. And this drug, it really has a great benefit for the motor symptoms, and so it can definitely improve, the patient's overall quality of life. It's generally well tolerated as well. Of course, important to point out is these patients are absolutely being co-managed with neurology as well, but always important to be familiar with their, the disease process and the medications that they will likely be treated with. All right, so next up, let's talk about headaches. So a small portion of individuals that present with a headache actually require a referral to the emergency department for immediate imaging and evaluation. So those patients include anyone that presents with a thunderclap headache. This is a severe headache. It reaches its maximum intensity within a few seconds to less than a minute. Also, patients with neurological deficits, altered mental status, papilledema, visual impairment, or the possibility of carbon monoxide poisoning. All of those indicate an immediate ER referral. There's also a really helpful acronym, SNOOP-10. I did not come up with this. It's supposed to help you, though, remember red flags with headaches. And so if you look at it, it has 2 N's, 2 O's, and then 10 P's. That's the SNOOP-10. And so I'm going to read through these. I did not come up with them, though, but I think it's very helpful. So it stands for systemic symptoms, including fever, neoplasm, neurological deficits, onset is sudden, older than 50, and then the P's are pattern change, positional change, precipitated by sneezing, coughing, or exercise, papilledema, progressive headache with atypical presentation, pregnancy, painful eye with autonomic features, post-traumatic onset of headache, pathology of the immune system, and then painkiller overuse. All of those are good reminders for red flags with headaches. The presence of any of these does require, further evaluation with imaging, either MRI or CT. All right, so let's talk about the different types of headaches. So first up, let's talk about cluster headaches. So these headaches are often sharp or stabbing in quality, and they are unilateral. Remember this because cluster has a U in it for unilateral. A classic core feature, though, of cluster headaches is their episodic pattern. They happen in clusters, hence the name. A typical cluster headache can last between 15 minutes and up to 3 hours, and it can occur from 1 up to 8 times a day. A typical flare of cluster headaches can last between 6 and to 12 weeks. Patients can experience remission from their cluster headaches for 3 months, up to 12 months, even longer, but it has that episodic pattern. Autonomic symptoms, these are often present with an acute cluster headache, and they occur on the same side as the headache, so the ipsilateral side. So symptoms include ptosis or drooping of the upper eyelid, miosis, this is an excessively constricted pupil, excess tearing, nasal congestion. Again, remember it's on the same side that the headache is occurring, the ipsilateral side. So research suggests getting an MRI of the brain with contrast for the initial evaluation of all patients that are suspected to have a cluster headache, even if they are presenting with the classic symptoms of cluster headache, regardless of their neurologic exam. And this is because some patients that do present with these typical features of a cluster headache actually are found to have some secondary cause for their symptoms, such as a lesion on the brain. And so it's going to be really important that even if they present classically, they do get imaging done. First line treatment for cluster headaches is inhaled oxygen therapy. Oxygen at 100%, it's administered via a non-rebreathing mask with a flow rate of at least 12 liters a minute, and the patient should be sitting in the upright position. The oxygen therapy should continue for 15 minutes to prevent the attack from returning. And so sometimes it will take 5 minutes or even less after starting the oxygen for the patient to feel relief of their symptoms, but they should still continue for the full 15 minutes, again, to prevent the attack from reoccurring. Higher oxygen rates can be used, so up to 15 liters a minute. If the standard rate was not effective, you can try titrating that up. Triptans can also be beneficial for the acute treatment of cluster headaches. It's given either subcutaneously or intranasally. If you do give it in the intranasal route, it's really important that you administer it on the contralateral or that opposite side of the pain, because a lot of times, like we said, they can have those autonomic symptoms on the same side as the pain. So for example, like nasal congestion, which would prevent the medication from working and getting to where it needs to go. It's important to note that triptans do cause vasoconstriction, and therefore these need to be avoided in patients that have ischemic heart disease, history of stroke, Prinzmetal angina, uncontrolled hypertension, and pregnancy. For patients that suffer from frequent cluster headaches, the calcium channel blocker verapamil is used as preventative treatment. And then for patients that experience infrequent cluster attacks, a short course of glucocorticoids are sometimes effective at reducing the frequency of those from reoccurring. And a trick also that I came up with to remember cluster headaches and kind of everything that goes with cluster headaches is A-E-I-O-U, all the vowels, A-E-I-O-U. A stands for autonomic because you get those autonomic symptoms with a cluster headache. E is for episodic because the pain is episodic. I is for ipsilateral because those autonomic symptoms occur on the same side as the pain. O is for oxygen because oxygen therapy is first line treatment. And then unilateral, again, just remember that it does occur as a one-sided headache. So migraines are believed to be related to neuron dysfunction, and they're divided into 4 phases: prodrome, aura, headache phase, and then postdrome. So about 77% of patients with migraines experience prodrome. So these symptoms, they typically present 24 to 48 hours before the onset of the migraine. They can include increased yawning, mood changes, so euphoria, depression, irritability, food cravings, constipation, neck stiffness. So it's really kind of a wide variety of these prodromal symptoms that they can experience. About 25% of people with migraines experience an aura. So an aura can present with positive or negative symptoms. So typical positive symptoms include visualizations, so bright lines, shapes, objects, auditory symptoms, so tinnitus, sensory symptoms, so paresthesias, motor symptoms even, so sometimes these jerky movements. Negative symptoms, these include, loss of vision, loss of hearing, loss of feeling, loss of ability to move part of the body. These are very alarming to patients, definitely, and they oftentimes can be concerning if the patient is having a stroke. But this does occur in some patients with migraine with aura. Most common auras, though, are the positive symptoms, the visual symptoms. Those are the most common with an aura. The migraine phase, it's a headache that typically is unilateral. It can be bilateral, but typically migraines are unilateral. And they have like this pulsating quality. So typically the patient also can report photophobia and phonophobia, so the sensitivity to light and sound. And then during that post-dromal phase, patients often feel either exhausted, their body has feels very worn out and tired. Sometimes they can feel relief after getting through the course of the pain. Diagnosis, though, of migraine, it's made if the patient has 5 or more attacks in the last 4 to 72 hours, and if at least 2 of the following are present, including unilateral headache with a pulsating pain, that's moderate to severe intensity, a headache that worsens with activity, and then at least one of the following as well, so either nausea and vomiting, photophobia, or phonophobia. And those are the classifications that we look for when we're going to diagnose a patient with a migraine. Treatment of migraines is based on the severity of their symptoms. So for patients that are experiencing mild to moderate migraines, that's not associated with vomiting or severe nausea, then simple analgesics or NSAIDs or acetaminophen, those are the first line options. If they're unresponsive to those analgesics, the combined use of an NSAID with a triptan is also sometimes effective. When attacks are associated, of course, with severe nausea or vomiting, oftentimes too an antiemetic drug can be used along with analgesics to help with those symptoms as well. Generally, we want to advise patients to not use triptans more than 10 days a month or simple analgesics more than 15 days a month, because this can cause medication overuse headaches. And this is a very common complication associated with the overuse of these medicines. Migraine prevention therapy can be indicated for patients that experience migraine headaches 4 or more times a month, or if they're experiencing attacks that last 12 hours or longer, or if just overall they're experiencing a lower quality of life from their symptoms. Preventative treatments, there's a couple options. So beta blockers such as metoprolol or propranolol are sometimes used. Antidepressants such as amitriptyline or venlafaxine are also sometimes used. And then anticonvulsants as well, so valproate or topiramate. Those are often also used as another option as well. And so there's a couple different treatment availabilities there for preventative treatment if they're experiencing those more frequent and severe symptoms. All right, and let's also talk, of course, about tension headaches. These are the most common form of headaches. They have symptoms of a bilateral non-throbbing headache. It's typically described as either tight or band-like pressure. They're typically able to function throughout their day with this. They're uncomfortable, but they're generally able to function. Typically, there's no associated symptoms of nausea and vomiting, photophobia, or phonophobia. Diagnosis with this is made clinically with your patients that present with typical symptoms of that cluster headache, and of course, they have to have a normal neurological exam. Treatment for tension headaches, simple analgesics again, so NSAIDs, acetaminophen. Caffeine is oftentimes used as an adjunct therapy with tension headaches, along with the analgesics if that's not completely effective, and that's also shown to be beneficial as well. If they present, to you like in a clinic setting, and you have access to IV or IM ketorolac, this is oftentimes used as well. This is essentially like an injectable Motrin, but it's a injectable. It lasts a little bit longer and it's a little bit more effective. And so if it's an outpatient setting like that and you have access to that tool, that can be very effective for tension headaches too. For patients with frequent tension headaches, there's a wide number included here. So frequent is 1 to 14 days a month. Chronic is 15 or more days a month. And so it's kind of subjective there of how this really affects the patient's quality of life. But if they're having these more frequent headaches, preventative treatment sometimes is used as well. The antidepressant amitriptyline has shown to be the most effective in preventative treatments for tension headache. Temporal arteritis, this is the most common systemic vasculitis. It should be suspected in patients that are older than 50 years of age with at least one of the symptoms listed, especially if it's in the presence also of an elevated CRP or ESR, which we know to be inflammatory markers. So at least one of these symptoms: new headache or change in headache, abrupt vision changes, jaw claudication, unexplained fever or other systemic symptoms, and evidence of vascular compromise. Diagnosis of this, though, is confirmed with a temporal artery biopsy or an ultrasound. And treatment for this is high-dose systemic glucocorticoids. And it's really important to note that if these are initiated soon, before the patient even experiences vision changes, then there is less than 1% chance of vision loss occurring. That's if we start those glucocorticoids ASAP. All right, so let's change topics now and talk a little bit about vertigo. So, vertigo, this is a symptom that causes the illusion of movement, often worse with head movement, and is generally described as a spinning sensation, though not always. It's important for you to be able to differentiate between peripheral vertigo and central vertigo. Peripheral vertigo involves the vestibular system. Central vertigo involves the central nervous system, so typically either the brainstem or the cerebellum. And so obviously, we're very much more concerned about central vertigo, and if we're concerned for this, we need to send them to the ER, where they have lots of tests done, lots of consults. They're managed very closely in the hospital there. The most common cause of peripheral vertigo, however, is benign proximal positional vertigo. And this is associated with calcium debris within that semicircular canal, the posterior semicircular canal being the most common site. So patients with BPPV, that benign proximal positional vertigo, but for now on I'm going to say BPPV, present with recurrent episodes of vertigo that last 1 minute or less. Episodes are provoked by specific types of head movements, so looking up while standing or sitting, lying down or getting up from bed, rolling over in bed. All of these movements have been associated with causing these recurrent episodes to occur. The vertigo, it can also be associated with nausea and vomiting, but it's not sustained. Other causes of peripheral vertigo would be Meniere's disease or otitis media. BPPV, it does not cause prolonged or sustained vertigo. It does not also cause hearing loss, tinnitus, or neurological deficits. Nystagmus, this is sometimes visualized and it's either horizontal or slightly torsional. However, it never reverses in direction, and it's able to be suppressed with having that patient practice visual fixation. So have them focus on an object across the room for a full minute without losing their gaze, and they should be able to suppress that nystagmus. The diagnosis of BPPV is made in patients that have these recurrent brief, so less than 1 minute episodes of vertigo, and it's confirmed with once observing nystagmus during a provoking maneuver. So an example of a provoking maneuver would be the Dix-Hallpike maneuver, and this can elicit nystagmus, and it's again used to confirm the diagnosis of BPPV. First-line treatment for patients with BPPV is the Epley maneuver, so another fun maneuver to learn, and it helps to reposition the particles or debris in that inner ear. So you can actually do this in the office, or the patient can actually taught to do a modified version at home. I recommend if you're going to do this in the office, you try it at home first. It's the first time I ever actually did this, true story, was in the office. I did not follow my own advice and practice at home. And it's a little difficult, especially if you are short, like I am. I'm very short, and I had to get up on a stool, and the whole thing, it was not effective, and that's okay. But I do recommend that you try and learn it at home on someone else before trying to learn it on the patient. And like I said too, they can do a modified version. They can even look this up on YouTube and do this at home, and they kind of get on all four hands and knees on the ground, and they rotate their head in a way that's trying to reposition the particles themselves. But it's really just a very important education point. Now compare this to central vertigo, which we said involves the central nervous system. So this can occur from either brainstem ischemia, cerebellar infarction. Multiple sclerosis is also a cause for this central vertigo. The nystagmus that's associated with central vertigo, it can reverse direction. It can also be purely vertical or purely torsional. Huge red flag. Also, these patients seem to have severe instability. There are neurological symptoms present, and so definitely very symptomatic patients. They need to be referred and managed to the ER. All right, so we're going to switch it up again, and this time we're going to talk about dementia. So dementia is a gradual decline in cognitive function. It's most commonly caused by Alzheimer's disease. If cognitive dysfunction is observed or reported, generally either by the patient's family or those closest to them, then they absolutely should be evaluated for dementia. Patients are not going to come in complaining that they are concerned they have dementia. It's going to be the ones that are closest to them that are picking up on these signs and symptoms. So, screening for dementia includes the cognitive assessment, for example, the mini mental state exam or the Montreal cognitive assessment. Also, the DSM 5, they have criteria for major neurocognitive disorder. This is also known as dementia. So, it's as follows, and I'll read it here. So, there's evidence of cognitive decline from a previous level of performance in one or more of the following domains, including learning and memory, language, executive function, complex attention, perceptual, motor, social cognition. So it's a decline in one of those domains from their previous norm. These deficits definitely interfere with the individual's independence, their everyday living activities, and they're not occurring exclusively in the context of delirium, which I'll talk about in the next slide, or they're not better explained by some other mental health disorder. For the most common forms of dementia, memory and language dysfunction are generally always present. It's important to keep in mind that other possible causes for cognitive decline can occur. So we want to look at medication interactions. We want to evaluate for depression. B12 deficiency and hypothyroidism are also attributed. Patients that present with cognitive decline, they definitely need an extensive workup, and it can't automatically be attributed to dementia. And it's really important that they also get imaging to, further evaluate. So either an MRI or a CT. So this is compared to delirium. So delirium is an acute presentation, generally over hours to days, of those cognitive changes and behavioral disturbances. Delirium is a clinical syndrome caused by either a medical condition, substance intoxication or withdrawal, or medication side effect, and it's characterized by a disturbance of consciousness with the reduced ability to focus, sustain, or shift their attention. Clinical features of delirium include an abrupt decline, impaired attention and orientation, a fluctuating level of consciousness, incoherent or disorganized speech, and then variable fluctuating memory impairments. They require absolutely an involved workup, and they are managed in the hospital setting. All right, next up, let's talk about Bell's palsy. So Bell's palsy is a facial nerve palsy of the 7th cranial nerve, and it's possibly related to the activation of the herpes simplex virus. So diagnosis is made on clinical exam. The patient typically presents with acute onset of one-sided facial paralysis that does involve the forehead. It's obviously very important that we do a thorough neurological exam with these patients. If there are any atypical neurological symptoms, then these patients absolutely require a referral to the ER and they get emergent imaging done. So the treatment for Bell's palsy is high-dose oral glucocorticoid ASAP, preferably within 3 days of symptom onset. If the patient presents with severe Bell's palsy, so this qualifies as a barely perceptible motion of that affected side, if they have asymmetry at rest, if they have incomplete closure of their eye, or slight movement of the mouth, this is considered severe Bell's palsy, and it's recommended that we also use antiviral medication in adjunct to that high-dose oral glucocorticoids. The usual regimen is the valcyclovir, 1,000 milligrams 3 times a day for 1 week. Also, all patients with Bell's palsy should be assessed for the ability to completely close that affected eye. If they're having incomplete closure, then we really want to educate on cautious eye care to prevent corneal injury. So we can use artificial tears, eye protection, ointment, careful taping at nighttime to hold that eye shut during sleep. About 80 to 85% do experience a full recover of that facial nerve function by 6 months. The main risk factor for incomplete recovery would be severity of weakness at the time of their presentation. Cauda-Equina syndrome. So this is a rare complication of lumbar spinal stenosis, and it affects the nerve roots from L1 to L5 and then S1 to S5. These patients typically present with one or more of the following symptoms with acute back pain. So bladder incontinence or retention, fecal incontinence, saddle paresthesia, bilateral leg numbness or weakness, All of those are huge red flags associated with lower back pain or acute back pain. They require an emergent MRI. It can occur from infection, disease, traumatic injury, but if ever a patient reports those red flag symptoms, they need an emergent MRI. All right, so this slide, I briefly cover autoimmune neurologic diseases. You definitely could see a question or two on these diagnoses, so I want to give you a quick summary. So multiple sclerosis, or MS, this is the most common immune-mediated inflammatory demyelinating disease of the central nervous system. So MS is characterized by multifocal areas of demyelination with the loss of oligodendrocytes. These are the myelinating cells of the central nervous system, and then scarring of the astroglia, which are a class of neural cells. So myelination, if you remember, this is the process that produces that layer of myelin that wraps around the neuronal axons, and it assists with the transmission of electric action potentials. Features that suggest MS include onset between 15 and 50 years, relapse and remission of symptoms, optic neuritis, fatigue, heat sensitivity, and then there's something also called the Lhermitte sign. So the Lhermitte sign is a transient sensory symptom. It's described as an electric shock that radiates down the spine into the limbs, most often after flexion of the neck. It can be infrequent, or it can occur with even the smallest movement of the head or neck. Evaluation of suspected multiple sclerosis, it begins with a very obviously detailed history exam. All patients also have a brain MRI with and without contrast, and they're absolutely co-managed with neurology. Guillain-Barré syndrome, so most patients that have Guillain-Barré report an infection or some other event in the 4 weeks prior to the onset of Guillain-Barré. Upper respiratory tract infection and gastroenteritis are the most common infections reported, specifically Campylobacter jejuni. Gastroenteritis, this is the most commonly identified precipitant of Guillain-Barré. The typical clinical features of this include progressive symmetric muscle weakness with absent or depressed deep tendon reflexes. So decreased or absent deep tendon reflexes in the arms or legs, it's found in about 90% of patients with at presentation of this. So it's seen in the vast majority of patients. Lumbar puncture for cerebrospinal fluid should be performed in all patients to confirm the diagnosis of Guillain-Barré. The typical findings with a lumbar puncture in a patient that does have Guillain-Barré is an elevated CSF protein with a normal white blood cell count. All right, and then finally, myasthenia gravis. So myasthenia gravis, this is an autoimmune neuromuscular disorder characterized by fluctuating motor weakness. So there are two clinical forms of myasthenia gravis. There's ocular and there's generalized. In ocular myasthenia, the weakness is limited to the eye, so the eyelids, the extraocular muscles. In the generalized disease, the weakness can commonly affect ocular muscles, but it also involves a combination of other muscles and symptoms. So there's bulbar, limb, and respiratory muscles. Bulbar symptoms, so this includes dysarthria or slurred speech, dysphagia or difficulty swallowing, and fatigue with chewing. More than 50% of patients with myasthenia gravis do present with ocular symptoms of either ptosis or diplopia. Those that present with ocular symptoms, about 50% of those remain purely ocular in nature, and they don't have those generalized symptoms. The diagnosis of this is confirmed by the presence of autoantibodies against the acetylcholine receptor or against other muscle receptor associated proteins. All right, and then finally, this slide here includes cranial nerves. Definitely review these. You could get a question or two on them. I think I had a couple questions. I don't recommend that you stress so much over this, but it is very helpful to review these. You can take a look. There are some different memory tricks to remembering the cranial nerves. If you Google it online, one of them was pretty inappropriate, so I didn't put it here, and I kind of just put in a variation of that. And it's the phrase, "Oh, to touch and feel very giant vicious animal heads." So if that helps you remember, then wonderful. You can use that as a little trick. Another thing that I thought was really helpful was remembering that we have one nose and two eyes, and that kind of helps you with remembering those first two cranial nerves, cranial nerve 1 and cranial nerve 2, one nose, two eyes. Personally, I put a few together that I've seen most questioned on. So, for example, cranial nerve 2 and cranial nerve 3, those are involved with the pupillary light reflex. Cranial nerve 5 is involved with facial sensation and mastication. Cranial nerve 7 is involved with Bell's palsy, which we talked about a few slides ago. And then cranial nerve 11, this is involved with head rotation and shoulder elevation. Of course, like I said, those are just ones that I feel like I've seen most questioned on. Definitely review them. But again, don't over stress yourself on these cranial nerves. I know some people get really worked up on trying to remember all of them. You will likely see a question, but it'll probably only be a couple. Alrighty, so that's going to complete the lecture all about neurology. Go get some water in you, move some legs, move your body. Come back after you've had a nice long break, and we'll do our next lecture.